Welcome back, everyone. This is Heather Drake again with the Maine Public Health Association. For those of you who were just joining us, we had a quick turnaround, so hopefully you were able to do what you needed to in that minute and get settled in for another presentation. But welcome to anyone who is just joining us again. We'll be continuing the conversation with Dr. Keena Thakrar, this time about injections and infections and understanding harm reduction in Maine. Just a reminder to please complete the session evaluation that you'll find on the session page. And if you have any questions, you can enter them in throughout the presentation using the Ask feature, and we'll address those at the end. If anyone missed the first introduction, Dr. Keena Thakrar is an assistant professor of medicine with Maine Medical Partners and Tufts University School of Medicine. And we're happy to have you here. So thank you so much for presenting again.
Yeah, great. Thank you. The title of my talk is Injections and Infections, Understanding Harm Reduction in Maine. Although the date says October 7th, we did not go back in time. It's still the 8th. I have no disclosures other than the funders listed here. And here's a brief outline of the talk. And just to give some background information for this study, so, nationally, there's been this rising rates of hospitalizations for bacterial infections in the setting of injection drug use. And this was a study that was published a few years ago, but the first column shows a few different types of infections that we commonly see on the infectious disease service at the hospitals, such as endocarditis, pretty bad heart infections, osteomyelitis, septic arthritis, epidural abscesses. And the second column indicates the number of hospitalizations in 2002. The third column indicates the number of hospitalizations in 2012. And as you can see from the numbers, there's a significant increase in all types of injection drug use associated infections over this 10-year time period. And that trend has certainly continued from what we're seeing. And this was a study actually that was published recently by one of the preventive medicine fellows at Maine Med, Dr. Nenninger, looking at specifically opioid-associated infective endocarditis. And this was using the national inpatient data set. And what our study team found was that, as you can see from the table there on the left, in rural areas, the rate of infective endocarditis went from 0.28 to 3.86 per 100,000, compared to urban areas, 1.26 to 3.49 per 100,000. And the graph indicates this as well, where the urban areas are in the gray circles, the rural areas are in the black boxes. So, essentially, this study really showed that we're seeing this rising rates of these really serious infections, not only in urban areas, but particularly in rural areas as well. And this was a study done by one of the recent Maine Med graduates, Dr. Ramirez, looking at the cost of infections such as endocarditis. And so this was using some data that we collected at Maine Medical Center from 2013 to 2016. And as you can see there in red, the cost for someone with infective endocarditis related to injection drug use, the median hospital charges were $150,000. Among these 42 patients that we looked at, the total cost to Medicaid was about $5 million over 3 years. So, these infections are also, costly to the healthcare system, and our patients, can have very poor outcomes. And in terms of other infections that we're seeing related to injection drug use, in Maine, we're seeing rates of acute hepatitis C increase. These data are a little bit old, but from 2013 to 2018, there was an over 300% increase in acute hepatitis C. Maine had the 9th highest rate in the US at the time. And many of these infections are attributable to injection drug use. And similarly with acute hepatitis B in Maine, we've seen almost a 500% increase over time. Again, Maine had almost the 9th highest rate of acute hepatitis B cases in the US. Again, many of these were attributable to injection drug use. And so I think a lot of people here are probably familiar with syringe service programs, but I just wanted to review this briefly because this is really the basis of our study here. So syringe service programs, or SSPs, have been shown to really effectively counsel clients about safe injection techniques. And they've been shown to reduce the transmission of infections like the ones I just talked about. Particularly, there's a lot of data around HIV and hepatitis. And SSPs also deliver overdose prevention education and administer vaccines to clients. And they facilitate referrals for treatment if and when people are ready. And these are just some pictures of just some of the equipment that SSPs will hand out. And so, as I mentioned, there's a lot of great data around SSPs. This is one study that was published recently in my home city of Philadelphia, where they looked at the number of HIV cases that were averted by SSP legalization in Philly. So the orange line indicates the number of SSP cases from 1984 to 2014, and that red vertical bar indicates when SSPs became legal. And the blue lines are the forecasted new HIV cases. So they found that they had averted almost 11,000 cases of HIV over 10 years by legalizing SSPs. So again, HIV in itself is, it's a lifelong disease with costly treatment. So we know that there's some good data around SSPs. Now, regulatory barriers for SSPs do vary by state. If you tuned into the talk that we just gave, there is this concept of the one-for-one needle exchange, which is sort of like it sounds, giving one used needle or syringe and getting a clean one in return. But this can be really hard for people who live, far away from an SSP. And also there's different drug paraphernalia laws by state. Here are I put the rules from Maine here, but if someone possesses more than 11 hypodermic needles, they could get punished for this. And I left a picture here on the bottom right where you can see, a clean needle before someone uses it, and what happens if they reuse a needle. This can be very caustic to their veins, and we can see lots of infections from this. And so the title of the study that I'm going to be talking about is Rural Harm Reduction, Access, and Regional Trends. And we really did this study because we've been seeing this syndemic between infectious diseases and substance use disorders. And I'm part of a national work group, the Infectious Disease Society of America, where we came up with, policy recommendations to prevent and treat these types of infections. And I left the reference there in the bottom right, but basically, one of the main recommendations was to expand the access to SSPs. So at the time we started this study, you can see here that the orange counties were the counties that were deemed high risk by the CDC for HIV hepatitis outbreaks. And at the time of the study, the SSPs that existed in Maine were indicated by green stars. And as I mentioned, Maine was not in great standing. We had pretty high rates of acute hepatitis B and C, and about 10% of new cases of HIV were attributable to injection drug use. So here are the aims of the study. The first aim was to characterize knowledge, attitudes, and practices around safe injection techniques. And the second aim was to identify factors predicting SSP utilization and uptake of other services. And our goal was really to help provide some new information about SSP use in our state and to identify potential barriers. And the main hypothesis was that distance from an SSP would be an important predictor. And here's our study design. We recruited participants that were hospitalized with injection drug use associated infections at 4 different hospitals in Maine that you can see there. And over an 18-month period, we enrolled a convenient sample of 101 participants. And unfortunately, our recruitment was cut short by COVID-19. But we collected data through patient survey and also through electronic health records. And our main outcome, our primary outcome, was SSP utilization. We also looked at several other outcomes, as you can see there, although we will be mostly concentrating on SSP use. And the main outcome, again, was past 3-month SSP utilization. We also looked at clean needles and syringes. As you can see from the bar graph in red, there on the left, 65% of our 101 participants reported past 3-month SSP use. And as you can see from the bar graph on the right, 10% reported that they always use a clean needle and syringe each time they injected. And this table is just a snapshot of some of the demographics that we looked at. The first column indicates a few of the variables, and the second column is the overall study population, 101 participants. The third column are the 65 participants who reported SSP use, and the fourth column are the 36 participants who reported no past 3-month SSP utilization. And generally speaking, this was a young study population. The median age was around 35. It was mostly white. 55% were female. And a majority, as you can see highlighted in red there, 57% lived more than 10 miles from an SSP. And among the 36 participants who reported no past 3-month SSP utilization, 81% of them lived more than 10 miles from a syringe service program. And as I mentioned, we did look at some other outcomes such as medications for opioid use disorder, naloxone, clean drug equipment uptake. And generally speaking, as you can see highlighted in red there, the uptake of all of these services were higher among people who reported past 3-month SSP use compared to those that did not. And we asked our study participants a lot of questions about what drugs they were injecting, how they were injecting. And one of the questions we asked was their injection drugs of choice. And so as you can see from the bar graph, most of our participants reported opioids, specifically heroin, as their drug of choice. But as you can see from the blue arrows, about 30% of our population reported stimulants as their drugs of choice. And I think this is really reflective of what we're seeing on the national level as well. And I think also speaks to the need for harm reduction services, given that we don't have great pharmacotherapy for stimulant use. And this is a busy slide, but I just wanted to provide sort of a snapshot of some of the injection practices that we asked our participants about. And so the practices that are in orange indicate practices that were rarely or never done. Yellow indicates something that was done some of the time, and the green color indicates something that was done half the time. So generally speaking, most of the study participants weren't using new needles or filters, cookers, or sterile water, et cetera. And these two practices I found particularly interesting because I'm an ID doc, but most of the participants reported licking their needle, and many reported re-injecting it as well. And again, one thing that I learned are these are practices that I can talk to my patients about in order to try to prevent some of these infections, because we are seeing a lot of injection drug use associated infections from oral flora or skin flora. We also looked at something called the Bacterial Infections Risk Scale, or the BERSI scale. And I won't go through all of the variables in this talk, but I just wanted to mention two specific practices. So one was hand washing and the other was use of alcohol pads. And most of the time people said that they were not doing either of these things each time they injected. And in terms of syringe acquisition, again, 65% of the participants reported past 3-month SSP use, but when asked about how frequently they used it, only 36% said they actually used an SSP regularly. And a majority of participants reported trouble accessing SSPs. And again, a majority lived more than 10 miles from one. And this map was created by one of my colleagues in Boston, where the metropolitan areas are dark brown, and more rural counties are the yellowish color. The SSPs are indicated by red dots, and it has sort of this red circle that's a 10-mile buffer zone. So it just gives you an idea, of how far people had to travel. Again, this was at the time the study started with the existing SSPs at the time. And in terms of syringe disposal, when we asked where people, got rid of their equipment, 70% of participants reported keeping needles to reuse on themselves. Again, I had showed this picture earlier, but that's certainly, concerning from an infection point of view. 30% reported disposing needles in the trash, and 27% returned their needles to the closest SSP. Now, we asked our participants about overdose risk and prevention as well. So 48% of participants reported naloxone uptake, which we defined as having naloxone used on them or used on someone else. And most of them reported receiving naloxone from an SSP. And as you can see from the pie graph on the left, a majority of the population, nearly 90%, reported injecting alone in the 30 days prior to hospitalization. And I think that speaks to, the stigma associated with substance use disorders and the fact that this was a very high-risk population in terms of overdose. And the second pie graph indicates that 86% of our study population supported supervised injection facilities, or SIFs. If you tuned into the talk just before, we talked a little bit about those, which are medically safe places where people can go to inject drugs. Not yet, uh, there are no sites yet in the United States, although they've been adopted around the world. And the third pie graph indicates that 95% of our study population were interested in mobile harm reduction units. Particularly, I think this is interesting given our rural population. So we did look at, whether or not people were on medications for opioid use disorder. The pie graph on the left shows that 66% of our study participants were on medications for opioid use disorder prior to admission. And, I think this is really interesting. And again, I think speaks to the need for harm reduction services, especially since we're seeing a lot of stimulant use, and, buprenorphine and methadone are not meant to treat stimulant use. And looking at the pie graph on the right, you can see that a majority of the population were treated with buprenorphine. So in our Maine analysis, we found that distance was definitely a barrier to accessing syringe service programs. And people who inject drugs were 5.5 times more likely to use an SSP if they lived within 10 miles of one. And that was controlling for homelessness, history of overdose, having a primary care physician, gender, and age as well. So in conclusion, we found that unsafe injection practices are very common, and there were certain specific behaviors and techniques where more counseling could be helpful. I mentioned the people licking needles or reusing them. And again, I've been taught that this is often part of ritual for folks. But again, as an ID doc, I think it's always good to talk about these practices with patients. And we also found, again, that access to clean equipment is definitely an issue. And as I just mentioned, there was a lack of consistent SSP utilization in our study population, and distance was definitely a significant barrier to people using SSPs. So some take-home points, from our studies, that we found that we really need to increase access to SSPs, particularly mobile harm reduction units in rural counties. Consideration of relaxed policies, such as the elimination for a one-for-one needle exchange, may make it more easier for folks coming from long distances to be able to take as many clean, needles and syringes as they need to. I'm happy to say that during COVID-19, especially, there's been a lot more SSPs that have been established, including more mobile ones. So I've been very happy to see that since the study started. And also, I think given that our study population did support supervised injection facilities, and given the evidence around them, these are actually two photos from the supervised injection facility I visited in Toronto a few years ago. I think that these are places where we should definitely be considering, given the overdose risk and infection risk in our population. So I wanted to say thank you. Feel free to email me or find me on Twitter. This is my son with his new friend, Dr. Fauci. And just a plug for the Maine Harm Reduction Conference. If anyone is interested, I think registration is open now. And I think that's it.
Great, thank you so much. That was a great presentation. And as we move into the question segment, a reminder to please use the Ask feature if you have any questions for Dr. Thakrar. We have had a few come in. One is from Kate. She wants to know, in some corners, she's been told that we're shifting from harm reduction to health promotion when talking about syringe exchange. Have you encountered this, and what are your thoughts about the potential language shift?
Well, that's interesting. I actually have not heard that yet. I'm not surprised. I feel like there's always constant changes to the language in the addiction medicine world, at least. but we use the term harm reduction quite frequently. What I have heard is, not using needle exchanges per se, but syringe service programs, really trying to get the point across that, these services are not just about giving a needle to someone and that's it, but they're actually, more holistic programs where, as I mentioned, you can give vaccines, you develop relationship with people where once they feel safe, they can, be referred to treatments. So, I mean, health promotion also sounds good, I think, as well. But thank you for bringing that up, and I'm going to have to look that up.
We have another clarifying question. You talked about the endocarditis study and that they paid money, or money was paid by Maine Medical Center. Was that charity care or other?
I think a lot, I want to say that was also through free care, I think. And then a lot of it was through Medicaid as well.
Thank you for that clarification. And this one also comes from Kate, and hopefully I'll get it right. There tends to be a lot more pushback from rural residents about syringe sites. Do you have any data on public perception from people living in the communities?
That's a really good question. And we did not, necessarily address that in this study. I think in the literature, at least from supervised injection facilities, I know that public safety is definitely one of the concerns. And, I think there was actually why Philadelphia, had been ruled not illegal to have a supervised injection site, but it didn't happen because of sort of public concern. So around syringe service programs, specifically, I think anecdotally, yes, there's always some concern there, but I don't know the literature offhand, but that's a good question.
Thank you. And are there other questions from the audience? I'll pause for a second to see if any more come in. Doesn't look like any more. So I think we can go ahead and wrap up. And I really want to thank you, Dr. Thakkar, for being here. For both of your presentations, they were really great, especially with the times that we're dealing with, to talk more about these specific populations. So we really appreciate you being here today. Please don't forget, for those in the audience, to complete the evaluation. And we'll be back in about 15 minutes with another presentation. So as I'm talking, we just got another question, so we do have time, so I'll take that.
Yeah.
But again, don't forget to take the evaluation. This question comes from Jay, and he wants to know, are SSPs in Maine generally finding that they're at capacity?
That's a good question. And my understanding is no. There's now actually 13, if I remember correctly, now 13 SSPs in the state. And that includes, the established sort of brick and mortar SSPs, but also the mobile outreach through, for example, Maine Access Points and Health Equity Alliance. So my understanding is that they're not at capacity. I think what the issue has been, like during COVID, has been obviously, trying to secure equipment like alcohol wipes and hand sanitizer and all of these things. So, if you tune into the first talk, we talked a little bit about that, but I think there's been a lot of sharing among SSPs with equipment and things like that. But I think that they're, walk in or call them, text them, and they're there.
Right. Thank you. And that's a really good question.
Yeah.
So now, with that, unless there are any other questions, we'll wrap up this session, and we will be back at 2:10 to continue the opioid conversation and substance use disorder conversation with a presentation by Doug Dunbar. So we hope to see everyone back. And again, thank you so much, Dr. Thakkar. And we will see everyone soon. Thanks.
Thank you.